Hello, dear colleague. I would like to present a talk about how to start and become a proficient in any technique, and I will use the endoscopic spine as an example. I built this approach actually from my experience in learning and upgrading my skills in the last 8 to 10 years. This presentation is part of from the chapter of book that will be published soon. So let's start it. My name is Ghazwan Hassan. I'm an orthopedic spine surgeon working in Al-Kindi Teaching Hospital. Currently, I'm the chair of AO Spine Iraq. And nothing to disclose of my talk. Learning objective, I will give you a rapid review about the endoscopic spine surgery and review the learning theory and my approaches how to start and become a proficient. If you review the timetable of the endoscopic spine surgery in the last 50 years, which is when in 1995, in 1950, when the vertebral biopsy cannula has been described by Rex in 1956, and later on progression of many techniques, especially in the last 2 decades when in the interlaminar transforaminal laparoscope has been introduced, and then the UBE technique, and in the last few years the virtual reality, robotic surgery, and the navigation has been applied also to this technique. So the MIS task force group in AO Spine classify the endoscopic spine surgery and give this classification according to the site, approaches, and the pathology as you see in this slide. When we review the evidence-based medicine in the endoscopic spine surgery, we have lots of paper with high level that's compared the endoscopic spine, and here in my example I'm using the UBE as an example. Many techniques that compare the UBE to the tubular open microdiscectomy, PLED, interbody fusion, and other evidence. So concerning the UBE, it's now currently used for primary disc herniation, recurrent cervical disc, lumbar stenosis, dorsal, and even for a few rare pathology that's including the facet joint, foraminal stenosis, and lipomatosis. When it's come to the learning techniques, we learned before that the teacher give the instruction to the students, and this is what's called the pedagogy. While in our example, and to learn and to get most of the knowledge we have to apply what's called the Andragogy, in which that we share between us the information and the knowledge in order to learn. And the 10,000 rules that's described by Bill Gates, in which working that 7 hours a day for 3-day weeks for 10 years, and to reach the expertise. From my perspective, it's not applied because simply now I'm 40, so I will be 50 like that to learn one technique. While the Andreas Eriksson described what's called the mental representation in his book, and is the key for upgrading the knowledge, and by applying what's called deliberate practice, in which the core component of it depend on the specific goal, intense focus, immediate feedback, and go out of the comfort zone. The motor skill acquisition described the learning the skill started from the cognitive, that's what to learn and how to do it by associative, and then end up with autonomous, in which that you do. And this is currently applied in our technique when we are performing surgery. While the social learning depends on the attention, retention, reproduction, and motivation, the deliberate practice principle, including that pushing beyond the comfort zone, work toward a well-defined specific goal, focus to intensify and on practice activity, receive and response to high quality feedback, and then lastly, develop a mental model of expertise. The motor simulation, which is another example of learning, that's in which you imagine the skills that you want to learn, and can be applied in some sort of sport, as you see in this picture. So to summarize the theories, the current body knowledge of the psychomotor skills acquisition to an expert level required observation of the skill demonstrated by the expert, interlies with the motor imaginary, mental practice and repetition, and then physical deliberate practice. So now I will start my approaches with 12 steps in order to reach the mastery in any technique, not only in the endoscopic spine. I personally applied in many techniques in the spine surgery and other field. First, you have to define your goal. Why? Start with why, as Simon Sinek described it in his book. This why will depend on the need, purpose, motivation, and self-progression. Then you have to set what's called the SMART formula for goal setting, in which the goal should be specific, more measurable, achievable, realistic, and timely. This is a critical point, because your goal to learn the endoscopic spine or any other technique should be based on this setting, and you have to apply a measurable, attainable, reliable, and timely consigned goal. To start with the knowledge, we have tons of reference that's available right now, including the article, books, video, courses, and this is very important to build up a knowledge before starting to practice any surgery or any technique. And then mentoring, I personally like it, and I applied in my life, not only in the surgery, because the mentor will give me support, will orient me to the goal, training, motivation, advice, success, and even direct me toward achievement. So you can get the mentor from the fellowship, learning his technique, teach you the tips and tricks, and learn you how to start and develop a feedback, support, and expert opinion. These are my mentors that's available in my practice. Overcome the struggle. This is one of the another steps that's applied, and we don't have in my country we don't have advanced centers to do such sophisticated advanced surgery. So I had to overcome by pushing the hospitals, try to get some instruments, and even buy some of these instruments, make it available, and then you in order to do and start the surgery. Otherwise, it will be not logical that you can do your surgery without availability of these facilities. Easy start, as I like it to name it, because you have to, when you learn any technique, you have to start with the easy cases. It's not logical that you do let's say difficult, complicated cases, and also it's important to avoid the revision, deformity, and diffusion in case of endoscopic spine surgery. So on the left side you will see the single level disc, which is a good candidate to start with a surgery with endoscopic spine, while in the right side you will have advanced degenerative with spondylolisthesis, which is not an ideal case to start with. Wopiage and et al. In 2021 give what's called endoscopic ladder of competence progression model, in which they define the ladders into the 4 levels, and they put every steps of the endoscopic spine surgery, that's including the UBE technique, and how they proceed with each technique. So it's logic to start with the left-sided disc and then proceed with other difficult cases, including the stenosis and diffusion. Backup surgeon, this is very important and applied, and I use it and apply it, especially in the initial cases. It will secure you and guide you during the surgery, and also it's very important to overcome the obstacle that's happened during surgery. Personally, I use it when I invited Professor Anand Karvi from India to Iraq to join me with some initial cases. Plan B, this is important and not only applied in the surgery but in our life. You have every time we have to plan to give other plan other than one plan. So in case of endoscopic, keep in mind and discuss with the patient about the possibility of conversion to microscopic or even to the endoscopic surgery. Feedback loop. This is, as I mentioned, in the delivery practice is one of the cornerstone. And when you review, by reviewing your surgery, review the recorded clips, time of the surgery, patient outcome, and the indication for the conversion in each step that you convert the surgery. And then ask the expert, when you collect all the data and all the obstacle and you have any difficult cases, start to ask the expert by sharing with them the information about the patients and the radiology in order to guide you and give you some recommendation. And as I applied in many cases from the expert of that pathology according to the indication. Measure your progression. This is very important, as you have to measure your surgical time, patient outcome, intraoperative struggling, and level of the cases, and also the complication rate and how can you deal with it and to avoid it in the future. And lastly, mastering the level. This is when you have, let's say, good number of the cases, you start to upgrade your level toward the complicated cases, doing revision surgery, publish your work, start to teach others, and measure your learning curve. And I will leave you with this video about one of the surgery, new BE technique. Enjoy in time, and thank you.